My name is Zeenat Safdar. I'm the director of the Pulmonary Hypertension Program at Houston Methodist Hospital, Weill Cornell Medicine in Houston, Texas. And I'm going to talk about my poster that I presented at ATS 2017. The title of the poster is Single Center Experience in Transitioning PAH Patients from IV Epoprostenol to Oral Selexipag. The objective of the study was to determine the safety and efficacy of switching patients from intravenous prostacyclin to oral IP receptor agonist since it has become available in stable PAH patients. PAH patients have severe disease and they require intravenous prostacyclin therapy. But some patients can be transitioned off to oral agents if they are stable. This study was undertaken to determine the safety of this transition and also the efficacy of this transition. So in this study what we did was we identified patients who were clinically stable PAH patients who had repeated line infections, or they have thrombosed vessels with poor access, or at patient's request to be considered for this transition. We developed individualized transition plan that was given to the patient and to the specialty pharmacy with a close follow-up. Patient was started on 200 microgram BID of Selexipag and instructed to go up every week by 200 till they reached a maximum dose of 1600 mcg BID. And at the same time during this, patients were instructed to go down on their prostacyclin dose by approximately 2 nanogram per kg per minute. Patients were instructed to tell their physicians and specialty pharmacy if they had any symptoms, any worsening of symptoms. Our main result shows that patients were safely transitioned and they completed this transitioning protocol, which means going off their IV EPO and coming to the lowest IV EPO dose and maximum Selexipag dose at home. The time that it took for this was about 2 to 3 months. The dose of EPO before they were selected for transition ranged anywhere from 9 nanogram to 38 nanogram per kg per minute. At the time of taking them off, patient underwent a right heart cath. The successful transition patients were those who had normal hemodynamics at the time of the right heart cath, and at that time, after reviewing their hemodynamic numbers, the epoprostenol dose and pump was switched off. Patients were monitored for additional 30 minutes in the cath lab, and then they were sent home. Patients who failed transition were the patients that at the time of their heart cath did not have normal hemodynamics, and those patients were instructed to go back on their titration so that they did reverse titration, going down on their Selexipag and going up on their intravenous prostacyclin dose. None of these patients were, during this transition period, none of these patients were admitted to the hospital with worsening symptoms. All of them, even those who failed and those who were successful, tolerated this transition protocol very nicely. No adverse effect was noted. Patients, however, complained of increased headache or nausea, vomiting. Those patients were instructed to go down on their intravenous prostacyclin dose at a faster pace. Out of these 8 patients, 4 patients were successfully transitioned off their IV epoprostenol. However, 4 patients could not be transitioned, and the reason for that is their hemodynamics were not normal at the time of right heart cath. Patients that were successfully transitioned on an echocardiogram, they had normal RV size and normal RV function. They had no pericardial effusion. Those were 2 things that were deemed important. There was no correlation between the dose and patients that were successfully transitioned. So in conclusion, carefully selected stable PAH patients who have been on stable intravenous prostacyclin therapy, meaning no change in their prostacyclin dose, no recent hospitalization, no change in their functional capacity, who have normal right atrium and right ventricle observed on an echocardiogram, can be safely transitioned to an oral IP receptor agonist. However, we need long-term follow-up to determine the durability of this transition. Thank you for your attention. I will appreciate any feedback.